Hi, good morning. My name is Bala Ambati. We'd like to welcome you to the Orbis CyberSight webinar, Managing Astigmatism at the Time of Cataract Surgery. We have an excellent panel today. Dr. John Doan from Kansas City, Dr. Vaishali Vasavada from Ahmedabad in Gujarat in India, Dagny Zhu from Envision Eye Centers in East LA in California, and my great friend Jerry Hu from Texas Eye and Laser Center in the Dallas-Fort Worth area. I think what you'll find today is that each of the speakers is presenting a different prism of perspective in terms of how to best approach astigmatism at the time of cataract surgery. Our real goal for today's webinar is to demystify management of astigmatism. Sometimes it can be a very formidable or difficult thing to manage with, and we're going to attack the problem of astigmatism in terms of expectations, alignment, measurements, and how to deal with complex situations. Our first speaker today is going to be Dr. Vasavada from India. Her talk will be about the management of expectations, how to approach and properly discuss toric lenses to avoid the unhappy patient. In our field, we often think about 20/20, but really we need to think about 20 happy, and how to achieve patient expectations is critical.
Thank you so much. Good morning, good evening, wherever you are on the planet. And thank you, Dr. Ambati, and to CyberSight for having me in this very important webinar. So today I really want to discuss what I find useful, or what I think helps me in managing patient expectations, but also in really approaching the whole concept of astigmatism correction and how we can have happy patients. I must declare that I do receive research support grant from Alcon Laboratories. So before we start off, I just wanted to understand from the audience perspective, and can we have the poll question online, please? The question being, what is your threshold for corneal astigmatism correction today in cataract surgery? And you have 4 options. And let's vote for the next, I think, 20 seconds. So yeah, it seems like most of us, 40% would go for toric IOLs when the astigmatism is more than 1.5 diopter, but a large majority, another almost 40%, would treat anything above 0.75 diopters. And there are about 20% people who don't use toric IOLs. And I hope this webinar helps them to sort of move on, or to start with toric IOL implantation, because really they are a great tool in correcting corneal astigmatism. Now, I want to start with this survey, which was conducted by the American Society of Cataract and Refractive Surgeons in 2018. And this is a little old data, it's 5 years old, but still at that time, most ophthalmologists do agree that astigmatism needs to be addressed at the time of cataract surgery. And yet, even in one of the most developed nations in the world, only about 22% patients received toric IOLs at that point of time. So then what are the key factors? Based on this, we must understand that there is a long way, wherever we are in the world, there is a long way for us to go and correct astigmatism, particularly with toric IOLs. In my mind, the 3 main factors are: one is to recognize the astigmatism, second is a very meticulous evaluation, and third is conveying these technologies, conveying the limitations of these and what to expect to the patient, which sometimes is one of the major challenges. So to understand this, how do you understand astigmatism and therefore approach it with your patient? We did a study of over 2,000 patients undergoing cataract surgery in our center, and we found that, as you can see here, about 56% of them had at least half a diopter or more of corneal astigmatism, and this is something which is now correctable with toric lenses very well. And there are other publications which have shown similar data. So that means at least 5 of your 10 cataract patients need astigmatism correction in one way or another. The other question is, does low astigmatism matter when it is about 0.5, 0.75 or 1 diopter? A lot of the old theories do say that having some amount of against the rule astigmatism might in fact help your depth of field. So we did a study where we randomized pseudophakic patients. These all had IOLs in their eyes, monofocal lenses, not torics. And one group was where the refractive astigmatism was 0.25 or 0.5 diopters. The other where it was either 0.75 or 1 diopter. And we focused on the finer aspects of vision, mainly the contrast sensitivity on the vector vision charts and the reading speed. And what did we see? When we looked at the contrast sensitivity unaided, the group 1, that means those who had 0.5 diopters or less of refractive astigmatism, significantly had better contrast sensitivity, particularly in mesopic conditions, as compared to those who had 0.75 or 1 diopter left behind. And even after the astigmatism correction in the form of glasses, this was very interesting that even if you gave that cylinder in their glasses, the group 1, that means those who had a lower astigmatism performed significantly better than those that had 0.75 or 1 diopters in mesopic conditions, particularly when you look at high spatial frequencies. So I think what we understood, and that has helped us push us or convey this to patients more confidently, our body language, the way we train our staff, the way we talk to our patients has changed, because we understand that it really this is a science that makes sense to correct at the IOL plane as compared to correcting at the spectacle plane. Also, when we looked at the reading vision of these patients, there was the reading acuity and the reading speed again were much better when you had half a diopter or less of refractive astigmatism. So I think the first and foremost thing that we need to understand as surgeons, unless we are convinced about any technology, surgery or IOL or glasses, it doesn't really penetrate or percolate that well to the patient. So we need to understand that correcting even the smallest degree of corneal astigmatism is important. Now, the other aspect which we must understand, particularly when you're beginning with toric lenses, is that what you measure on the cornea is only one part of the entire spectrum of astigmatism. What we also need to factor in is what you induce or what you are going to add after your surgery. And therefore, I think for most of us, if you're starting out, at least once in your surgical lifetime, it is a good practice to calculate your own surgically induced astigmatism, have at least 40 or 50 cases with the same incision size and location. And I think we have very good online calculators now, which will do that for us. So that really helps us to understand how much we are going to add to this corneal astigmatism. So let's take this example, and I must acknowledge Dr. Warren Hill here, who actually taught me this many, many years back, that if you have about 0.75 or 1 diopters of astigmatism, you are going to add anywhere between 0.1 to 0.3 diopters, depending on your incision size and location. So again, if you add this, particularly when the astigmatism is horizontal against the rule, you are going to probably add to this, and therefore a lot more patients become candidates for toric IOL implantation. So this is what I also wanted to encourage everyone to understand your own induced astigmatism. And I understand that we are going to discuss the pathway of evaluation and posterior astigmatism, so I won't go deeper into that. Moving on, once you know that it's good and it makes sense to treat astigmatism, why would you opt for a toric lens and not an LRI or an AK or glasses or contact lenses? So I think today this technology has matured to a level where it has become a component of a routine cataract. You don't have to do too much extra. So in terms of time or effort, it is not an extra procedure. It is just part of your normal cataract surgery. The most important thing is that the treatment is very predictable, it is very accurate, and there is no regression. You don't typically see regression over time. And if there is something wrong, if you put the wrong power or the wrong axis, you can always address that. So you are not in an irreversible situation where you have made a cut and you cannot undo that. So I think this is why I like to try and use toric IOLs more and more in my practice now. When you choose a toric IOL, if you want a happy patient, if you want consistently good results, it is also important to choose the material and the type of lens. Whatever material, whatever brand you choose, that's really up to your preference. But it should have a good rotational stability. It should have a good biocompatibility and adhesion so that the antero-posterior movement doesn't change the spherical refraction, the ELP, and it doesn't induce much inflammation. The good part now is that across the world, we have several manufacturers who make really high quality toric lenses. And this is a shot I took from one of the recently published articles, which tells us about what is the average rotation with different commercially available lenses. And this might help you to choose or to understand what is happening to your IOL. Now, I think the most important part in ensuring a happy patient is to make sure that you pay attention to every detail, because even in the modern times with all the good technology available to us, nothing beats a good scientific practice. And here I want to make only a few points. To me, what I find very useful is have a dedicated protocol or a dedicated time when your entire staff, including the optometrists, the counselors, yourself, you are all available to deal with those pre-operative patients. Often in a very busy clinic, you are seeing 10 or 15 patients, and there's this one patient who also wants a cataract surgery. So as far as possible, if logistics allow, it is a good idea to have a separate time that is allotted, so the patient also realizes the importance of the workup or the investigations that are going to be done. And you can always call in family or friends or the caregiver at this time so that they can also be active partners in the decision making. Always evaluate both eyes. I have experienced this myself and therefore have learned the hard way that it is sometimes you don't have astigmatism in one eye, and you do that eye, the patient is very happy. Now, when he or she comes back for the second eye, you realize that, oh my God, there's a 1.5 diopter of astigmatism. I never discussed toric lenses with this patient. And in those situations, particularly when the patient might have to pay out-of-pocket expenses, this might become a tricky situation. Or maybe one eye has a retinal pathology. So always do a complete pre-operative evaluation of both eyes, even if one eye is pseudophakic, even if only one eye has a cataract. So this is something I tell my team to enforce very strictly. Evaluating the ocular surface is a very often missed out aspect, and we may not do a Schirmer test for everybody, but using just doing the lid margin evaluation, look at the tear film, does it have all the debris or does it really have a lot of watering, folds on the conjunctiva, conjunctivocalysis, because all these surface problems are going to lead to an unhappy patient, even though your toric IOL is doing its job very well. How are dry eyes or ocular surface problems relevant to cataract or refractive surgeons? Well, one thing that we sometimes don't discuss is how it affects your biometry. So I want to show with this case example. Here on the left, you see is topography, a Placido topography prior to lubricants, and you can see these distorted Myers. And after treating the surface by just giving lubricants, this is how it becomes so regular. So from an irregular astigmatism, this patient right away goes to regular, and you can see the aberrations on the cornea in these large red and blue bars have dropped significantly. This is an optical biometry from a patient. On the left side, you can see the keratometry about 41.2 and 43. This patient was diagnosed to have an ocular surface problem, and after treating the surface, the keratometry has changed by almost 1 diopter, and even a spherical IOL, if you look at a monofocal lens power, the dioptric power has jumped by 1 diopter. So even if you do a good toric calculation, you put the lens well, a brilliant surgery, but if your surface was not good, you could have a spherical refractive error left behind, in which ultimately also mars your outcome or the happiness. Anything you do, if you have a manual keratometer, doesn't matter. You don't have to have an automated device all the time, but please be very precise and very particular in doing this. I've taken this picture to show, if you can notice, it's difficult to see here, but there is a slight tilt in the head. So make sure your patient is comfortable, well aligned. Even if you're doing an immersion A scan, Like I said, you don't have to have the most modern technology. A well-performed visual fixation and a well-performed examination will go a long way. Use the modern formulae. And here I want to put in a red flag of an irregular astigmatism. Uh, there are times when we need to respect the technology and we need to convey this to the patient that your eye may have a limitation or the technology has a limitation. And even if you want a toric IOL, your eye may not be suitable for this. Signs that make sense, depending on where you practice, the culture of the region where you live, involving key decision makers or sometimes the children or the spouse or their caregivers, might also help the patient in choosing the right technology for them or in understanding what to expect after surgery. And this is a picture I just took off online, and a lot of companies and the industry has good simulators which you can use to show them what happens whether you correct astigmatism or not. A small point I want to make about aberrometry. Here is a case of a 52-year-old man who has, as you can see, 1.2 diopters of corneal astigmatism, and you would straight away want to correct it. But when I talked about toric lenses, he said, but I've never worn any astigmatic glasses. Why would you want to implant a toric lens in my eye? And here is where technology came useful. This is taken from the eye trace aberrometer, where the blue bar that you see denotes the astigmatism on the cornea, whereas the red bar is the internal astigmatism, typically coming from the crystalline lens. This is a phakic patient. Now, as you can see, they are both balancing out each other in the opposite direction. So we need to understand and explain to this, use as much technology as you can to show this to the patient that right now your crystalline lens is working to accommodate your natural astigmatism on the cornea, but the monofocal lens cannot do this. So the patient finally opted for a toric lens. He took our advice. And here is a post-operative picture where again you can see this is another patient, but just to drive the point that the blue bar, which is a corneal astigmatism, this is a pseudophakic eye with a toric lens, is beautifully balanced out by the toric IOL. So I think in trying to convey or to talk to the patient using as much visual technology as you can also is very important. Nothing can beat a good chair time and discuss. Like I said, I come from a place where the family is also very important in making the decision and also in the post-operative outcome. So I think this is what came out from the survey that I showed in the beginning, that the cost and lack of training are important. So I think that is something we can work on. And I want to just put this last case of a share broker. He does a lot of stock market and he has always been myopic and has myopic astigmatism. He wants to continue reading without glasses after his cataract surgery. So what he wants is unaided good reading vision. So even with a toric lens, you can always correct the astigmatism and leave the patient myopic in the tune to about 2.5 diopters. And this is what we did for him. This is the IOL calculation from the Barrett formula. And he ended up both eyes the target that we wanted, but he's so happy because he can read without glasses. He still wants to wear his distance vision glasses. So like Dr. Ambati very nicely said that it's not 2020, it's happy. What the patient wants and what you want should typically be in line with each other. And my final slides, you do need to tell them that we cannot ensure a zero astigmatism. We might need a touch-up in the form of a rotation or repositioning. This is not a completely mathematical process and every eye can behave differently. And I think the last point I want to make is that if you want more happy patients, the team should be geared up and their body language, their confidence should show. And that's why training your team and showing them how your toric IOL patients are doing will go a long way in ensuring happy patients. And trust me, this is a very forgiving technology. So I think it is time we all push more and more toric lenses for our patients. Thank you.
Thank you very much, Dr. Vasavada. That was a terrific opening presentation. I really appreciated your point about educating the patients. And what I've realized just in the last few years is that even many referring doctors don't tell patients they have astigmatism. And if it's the surgeon who's first informing the patient they have astigmatism, that trips up the conversation. That adds another layer of education. So the more you can have your staff and your referring doctors bring the patient up to speed that they have not just cataract, but also astigmatism, and specifically astigmatism on the cornea, then the easier your job becomes. There's a few questions in the Q&A. So first one, Dr. Vasavada, what are the minimum imaging modality requirements for toric IOL selection?
So I think this is a great question that not everybody may have access to everything. In my understanding, when you're starting off, what you need is a good keratometry. You could have a good manual keratometer, an automated one like the optical or the swept source OCT devices do a great job. But even if you don't have access to that, you're starting with an immersion A scan for a good axial length, a well done manual keratometry. And if your Myers are irregular or your astigmatism is either very low, below the tune of 0.75 or more than, let's say, 2 to 2.5 diopters, that's a time when I think that performing a corneal topography or a shine plug imaging really becomes important. But down the line, as you gain more experience, I surely think that having some form of corneal topography or shine plug will go a long way. And today, I think if you have one swept source OCT biometer, a good one, along with one topography, you are pretty much set. But that should not dishearten people who are in parts of the world where you may not have access to all the technology.
Perfect. Next question was, what are your suggestions about what to include in informed consent for toric lenses?
I think this is something that's really, really relevant and important in today's time. What we include in our consent is that we are trying to improve the quality of your vision. We never say we are giving you spectacle-free vision for distance or for near. We say that we are trying to correct your or reduce your corneal astigmatism. You may still need touch-up procedures, and you may still need occasional glasses despite the use of a toric lens. And this is not 100% guarantee for spectacle-free distance vision. I think these are the 4 points I do include.
And getting back to the imaging, the next question is, why is there a difference between Pentacam and IOL Master at LensStar? I just want to say that, in our practice, we average a lot of different modalities. We have astigmatism measurement from autokeratometry, from a shine plug tomographer, and from the Argos biometry. And so averaging seems to really help our practice. What do you do in your with your patients?
I think we pretty much, like you said, we also look at a shine plug, we look at an aberrometry, and we look at the swept source OCT. Essentially they measure different things. So you really can't have the same reading in all three devices, which we need to understand. But if you have in the range of, let's say, half a diopter and axis within 10 diopters of each other, then you are okay. For me today, my go-to instrument is my swept source OCT keratometry for both magnitude and axis, but I always look at the posterior cornea from the shine plug imaging and the regularity of the astigmatism, which I do both on aberrometry and on shine plug.
Perfect. Which swept source OCT keratometer do you use?
I have access to the Argos biometer, and I used to use the LensStar, which is an optical biometry, not swept source. That too was fantastic. And once you do a few cases, we should look at more than one instrument, but use one as your primary and then two others to sort of match or corroborate. If they don't match, if there's a huge variation, then I want to call in the patient again, repeat all the readings, and then sort of average out.
Yeah, terrific. Yeah, I mean, definitely when there's disagreement between devices, optimizing the surface and treating the patient for dry eye and repeating the measurements is critical. Next question is, what amount of astigmatism would you consider significant surgery-induced, surgeon-induced astigmatism?
So fortunately, with most of us who now use 2.2 or 2.4 clear corneal incisions, our induced astigmatism has gone down drastically, but anything more than 0.15 diopters is significant. So you should factor that in. And like I said, it's a good exercise to at least know what you're inducing, because sometimes you might be surprised, pleasantly or otherwise.
Perfect. And I think we'll do one last question from the audience. How long will you treat patients with ocular surface disease before repeating the keratometry?
In an ideal world, I would like to have at least 10 days or 10 days to 2 weeks. But it really depends on how bad the ocular surface is. If it's something where even after giving lubricants for a couple of days, you don't get reliable Myers or readings, then I will ask the patient to wait for 2 weeks. But usually in the setting where I practice, in private practice, patients are on shorter deadlines. So I think couple of days usually works for most cases.
Perfect. Well, thank you very much, Dr. Vasavada. Really learned a lot. And our next speaker is Dr. Jerry Hu from Texas Eye and Laser Center in the Dallas-Fort Worth area.
Let's see. So I do believe the ability and the practice to precisely measure astigmatism really lay the foundation to any effective treatment, including lens-based approach such as Toric IOL or cornea-based approach such as femtosecond laser AK or ocular keratotomy. So in the next 15 minutes, I'll show you quickly how I calculate and select Toric IOLs, and how I manage and handle posterior corneal astigmatism, and how I plan femtosecond laser ocular incisions. My disclosures. So this is a real-life patient who came in last week, a 60-year-old guy, best corrected vision of 20/40 and 20/30, confirmed to have 2+ nuclear sclerosis. I did his right eye last Thursday, so I'll just focus on his right eye. So his corneal topography, his auto refraction, his manifest refraction, his auto keratometry, and the barometry all showed a relatively small against the rule astigmatism. So my question for the audience is, how would you manage this patient? Now remember, 3 out of the 4 or 4 out of the 5 devices showed a relatively small against the rule astigmatism. So here are the choices. So once do nothing, his astigmatism is kind of small. He may just see well without doing anything special. And the second is do a manual lingual relaxing incision. 3, a femtosecond laser ocular incision, or a toric implant, or maybe a combination of 2 or more of the above. Very good. So looks like the number 1 is the manual relaxing incision. I think the patient will do very, very well with that. And femtosecond laser, that's a surprise. That's the lowest. Maybe that's due to the availability of the technology. And so let's see what we did. Let's move on. It's always a good idea to take a thorough history. We all have had patients who conveniently forgot to mention their LASIK 25 years ago, right? And of course, like education and the planning before the surgery and the hand-holding after the surgery are every bit as important as the surgery itself. Cataract care is still complete eye care. If a patient's astigmatism is caused by certain ocular pathologies like keratoconus or corneal scar, we can still help the patient, but we may have to modify our approach accordingly. So the patient's current eyewear prescription and their current manifest refraction can provide valuable clues, although the true extent of the corneal astigmatism is often masked by their underlying lenticular astigmatism. Just how common is lenticular astigmatism? Well, it's very common in most of the patients. 85% of us, we have some degree of lenticular astigmatism. They are usually irregular, okay, and they tend to increase with age, but fortunately, they will be gone along with their cataracts. Lenticular astigmatism is usually also pretty small in magnitude, unless they're caused by certain underlying diseases. But the good thing is they're generally quite rare. So it's all about the measurements. How do I take corneal measurements when I see my patients? Well, I use auto keratometry and corneal topography on all patients. I also get a corneal tomography with Pentacam on many patients, especially if they've had previous refractive surgery like LASIK or PRK, or if they've had any corneal altering surgery like pterygium surgery, or if they have any corneal pathology. Pentacam is really indispensable in my practice in cases of previous LASIK where only the central cornea is flattened. I can render a special report with Pentacam and see corneal curvature readings at certain optical zone. For example, this is a previous LASIK, myopic LASIK case. And as shown in the picture, I take K readings at 4.5 millimeter optical zone. And also biometry has improved a great deal over the years. I've used Landstar, I still use IOL Master and Argos in my practice. Currently, my go-to biometry in routine cases is IOL Master 700. It's a sweat source OCT. The recent addition of true keratometry feature claims to be able to measure central cornea and the posterior corneal curvatures much better. So most patients have posterior corneal astigmatism, almost invariably against the rule. Some may have more significant amounts than others. It's not uncommon to see patients with half a diopter or even one diopter cylinder on the posterior surface. Until recently, nearly all keratometers could only measure the anterior corneal surface, not the posterior. Against the rule, astigmatism tends to increase with age. And the average patient has about 14% more against the rule astigmatism than what can be shown on their measurements. So currently, and for the last 15 years, I have relied on Aura, which provides intraoperative aberrometry to nail my visual outcomes with Toric IOLs, and also with post-refractive surgery corneas, as well as all other cases. As technologies and the newer generation IOL formulas improve, some of my colleagues have stopped using Aura. Well, I'm still getting great results with Aura. My enhancement rates for advanced technology IOL is only about 1 or 2% when I use Aura. And when I stop using Aura, my enhancement rate goes up to about 9 or 10%. So I'm still sticking with it. But my approach may yet change in the future, depending on the technology. So lingual relaxing incisions have been used effectively for many years to reduce corneal astigmatism. Recently, digital marking devices such as Callisto, shown here, have improved the accuracy of this approach. Femtosecond laser has allowed us to be more aggressive and even more accurate when we move relaxing incisions from limbus centrally to 9 millimeter optical zone, or even smaller as needed. There are different nomograms for where and how long these incisions should be. My own rule of thumb is about 30-degree arcuate incision for every half a diopter and 9 millimeter optical zone. So for 1 diopter astigmatic correction, for example, I'd like to make a pair of 30-degree arcuate incisions at 9 millimeters. And of course, let's not forget LASIK or PRK as valuable options in our toolbox as well. So in addition to cornea-based approach, we now have lens-based options for the last 15 years. Toric IOLs have become a mainstay in my practice. Every single category of IOLs now offer toric models, including monofocal, multifocal, extended depth of focus, and of course, light adjustable lenses. And Dr. Dong will teach us more later in depth on the light adjustable lenses. So let's go back to our patient from last week, our case study. So the patient desired a multifocal IOL to expand the range of his vision. So from the IOL Master 700 printout, I first selected the spherical power of 20.5 diopters, aiming plano. And then I decided on a toric model of T3. So how did I do that? Well, there are a plethora of online toric IOL calculators from ASCRS, ESCRS, Asia Pacific CRS, and every IOL manufacturer. You can use any of them pretty much with good visual outcomes. Which one do I use? Well, I happen to use none of them. So over the years, for the two main families of toric implants I use from Alcon and also the Technis family from Johnson & Johnson, I have committed their power tables to memory, and I just do my own calculation. So for this patient, I predicted a Panoptics T3 model with a power of 20.5 diopters. So this is the video of the case from last Thursday. So I'll just play the video. Here I'm doing a small 5mm capsulotomy to keep the optic in the bag. I do a 4.8mm capsulotomy when I use femtosecond laser, gentle phaco, cortex removal. I polish a lot. I spend more time polishing than phacoing, arguably. Refill the anterior chamber with OVD to an IOP of 20 to 25. Confirm with a tonometer to make sure it's not too firm or too soft. Aura intraoperative aberrometry, aphakic wavefront refraction reading. I take 3 readings. Each one has 4-day measurements. I pick the best one. And here I'm selecting the spherical power, target plano. And with that, I select the toric power. In this case, it's a T4 instead of T3. This is not uncommon, especially considering this is against the rule of astigmatism. The toric model often go up from the preoperative calculation. I remove OBD completely, especially behind the optic, to prevent IOL from rotating. Aura will then give me placement guidance as to where to align the toric IOL. And I leave a little hypotony to collapse the capsular bag to further stabilize the implant. Here I'm doing a small 5mm. All right, so within the first week after implantation, some toric IOLs may occasionally rotate spontaneously. The rotational stability of toric IOLs is very good nowadays. With the current models on the market, I'm seeing maybe a 1 or 2% rotational rate. As long as the spherical equivalent is on target, it's actually quite safe and easy to rotate a misaligned toric IOL. It spares the patient from needing a LASIK, which could make their dry eyes worse. I have done it up to a year post-op, but if you rotate within 1 to 3 months, you can simply reopen the paracentesis with a Sinskey hook. Then you use a cannula on a BSS syringe to rotate the lens. There's no need to open a corneal incision, and there's no need to use any OVD. So it takes a couple of minutes. And not much inflammation. Patients can see well almost instantaneously. The website astigmatismfix.com provides great guidance and step-by-step instruction for this maneuver. So I would highly encourage all of you, to incorporate toric IOLs into your daily practice. It's both rewarding and forgiving. You don't really need to be perfect. You don't have to completely eliminate their astigmatism to make patients happy. You just need to debulk it. You can use toric IOL. You can use femtosecond laser ocular incisions, or you can simply do a manual limbo relaxing incision. So the audience response, all the answers are correct. You can help this patient really well in a number of different ways. So as long as you do something to address patient's astigmatism, both you and the patient will be amply rewarded. So the old adage, close enough is good enough, actually does ring true in this scenario. Thank you for your attention, and I'll be happy to take questions.
Thank you so much, Jerry. Terrific talk. I really enjoyed the video. When do you decide you go with femtosecond AK versus a toric lens? What situations do you pick which?
Well, if it's under 1 diopter, for with the rule, astigmatism, I anticipate, the final, the true astigmatism will be less, so I would be more inclined towards doing the femtosecond laser. So basically, if it's 1 diopter or less with the rule, I go with femtosecond laser. And if it's 0.75 diopter or more against the rule, I anticipate the true astigmatism will be more than 1. So actually, will tap into the toric.
Terrific. We have a couple of questions from the Q&A audience. Do you undercorrect with the rule, and do you overcorrect against the rule astigmatism?
Yeah, that's a great question. I think one of the studies, well-known studies in pilots and astronauts, actually have shown that patients who actually see more than 20/20, right, 20/15, 20/12, 20/10, they actually have a slight amount of vertical like astigmatism. So that actually helps to improve the visual perception. So yes, indeed, I undercorrect with the rule, and I tend to be more aggressive and overcorrect against the rule. That's a great point.
So are you shooting for like about a quarter of with the rule astigmatism? Is that?
Yeah, I don't have to, if the 2 power recommendations straddle the perfect target, I just go with 1 power under for with the rule, and the 1 power over for against the rule.
Next question from the audience was, what's your favorite Toric IOL? Alcon, J&J, Bausch and Lomb?
Well, we have just done a study comparing, the Clarion toric platform and the Technis, the iHands Technis 2 platform, and it's a very well done study, and we actually the outcome is dead even. I'll just say that it's dead even. They are both very good. The rotational rate in that particular study was well under 1%, more like under 0.5% rotational rate. So they're very, very good. The mechanism is different. The Technis 2, has frosted haptics. I think it's really intuitive that it's stable in the bag. It's actually difficult to even rotate in the bag in surgery, whereas the Alcon platform, it relies on the fibronectin formation. So it takes more technique, but with the right technique, meaning if you leave the eye hypotenuse, you collapse the capsular bag to wrap around the haptic, you can get equally good rotational stability.
Yeah, that's a really terrific point. We're used to keeping a hard eye at the end of the surgery to minimize leak, but actually we may want to lower our end intraocular pressure to help optical recovery, as well as help keep the lens more stable. That's a terrific point. There's the next question is, how does one calculate their surgeon-induced astigmatism? Are you keeping track of all your cases?
Yeah, we've done that. Yeah, I would highly recommend all the surgeons in the first maybe 5 years to really keep track of it. And also, as your technique changes, as you modify your technique, always do another tracking. So I think 20 years ago, my surgeon-induced astigmatism was more like 0.2, but now with a 2.2 millimeter incision, really lingual, paralingual, not really clear cornea, so it's really 0.1. So for all practical purposes, I program 0.1, but it's negligible. And also a lot of surgeons actually advocate, operating on axis. I personally, I did that for years, but now, for the last maybe 15 years, I've chosen to operate off axis because I want to preserve the axis to future intervention. Manual lingual relaxing incision, can be done under oral guidance, under intraoperative aberrometry guidance can be done at the end of the surgery, and I want to preserve the axis to be able to do that. So I, in fact, make my incisions around the axis. I leave the axis untouched. just for that reason.
Gotcha. How many degrees of axis rotation would you consider for post-cataract surgery, rotation of the lens? Like, when would you intervene?
Oh yeah, so you pretty much they rotate usually within the first week. Occasionally in the second week, I've seen a couple, but usually within the first week. And by 1 week post-op, you will know if you're going to rotate or not. But I usually always wait till about 1 month out, because I want to get a good refraction. The ease or the difficult level of doing the rotation is the same at 1 week or 1 month. So at 1 month, I'll be able to know the true manifest refraction. If there's any spherical error, then rotation will not help you. Then I'll go straight to LASIK or PRK. But if the spherical equivalent is neutral, then I can go in at 3 or 4 weeks or even later. And as long as you do within the first couple of months, you can open up the paracentesis, do a very easy rotation, in a couple of minutes, you'll be out of there. And because you haven't done anything, you haven't opened up the wound, you haven't done OVD, there's minimal inflammation, and the patients can actually see within hours.
So when you open up just the paracentesis and you're using your BSS cannula, are you using a 27 or a 30 gauge? Are you using a long cannula, a short cannula?
You can do either one. I've used 27 and the 30. Yes, I've done both. Yeah.
Next question from the audience. Would you do toric lenses without a topography?
It's not just one topography. We have, on my desk, I have 5 different keratometry readings. Topography, some kind of topography, tomography, K readings. Like I said, refraction also can give us a clue. I would hesitate. And also the aura, you still need to, even if it's intraoperative aberrometry, you still need the preoperative axial length and the K readings in order for the aura to work. So I cannot think of a scenario where I would go in blindly and do toric lens without topography. I would get more than just topography, several different modalities of the K readings.
Yeah, I totally agree. I think it's very important to measure 2 or 3 ways and then do that before cutting. And so I think having the best measurements is critical. I am surprised by how many cataract surgeons don't have a topographer, and that's probably because I'm biased from coming from a corneal refractive fellowship as you are. But I think it is critical to get those topographic measurements. One last question from the audience. What measures do you recommend to reduce IOL rotation during surgery? Like how do you minimize the problem of IOL rotation?
Right. So I have mentioned a few. The number one is smaller wound. So I use 0.9 millimeter paracentesis, 2.2 millimeter main corneal wound. The second is a small capsulotomy opening. I used to make it bigger, but as I progress further, my capsulotomy opening is just getting smaller and smaller. So I use a 5.0 millimeter manually, and I use 4.8 with Femtosecond laser. And some of my colleagues, they are even doing 4.5. I think that helps. I polish a lot. Some of my colleagues, they leave a little lens epithelial cells there. They think the fibrosis will help stabilizing the implant. For me, it really, the fibrosis, the traction, the tethering can really change the effective lens position later on. And so I polish a lot, copiously. I spend more time polishing posterior capsule, anterior capsule all the way in the periphery, more time polishing than phacoing. And so that's another thing, because the mechanism of the modern generations of toric IOLs do not need all those fibrosis to lock it down. And finally, I leave the eye pressure very low. I burp the eye, I really collapse the capsule around the haptics, so it's not gonna move. And of course, I tell the patients, don't do any, don't run, don't jump, and refrain from strenuous activities for 1 week. And with that, still some patients, you'll still see some rotation. So that's why it's very important to have the tools, to have the skill set to deal with that. Having said that, I'm seeing about 1%, 1 to 2%. A rotational rate, but again, close enough is good enough. Even if they do rotate 5 degrees or 10 degrees for lower power toric lenses, patients will still do very well. But if it's a higher power, the T5, T6, even a 5-degree rotation will make a big difference. Patients will tell you. Yeah. So.
Yeah, absolutely. That's a very important point. The amount of significant rotation depends on how strong the toric correction is.
Exactly.
Well, thank you so much, Dr. Hu. Really appreciate your wisdom. And we'll move on to the next speaker. It's Dr. Dagny Zhu from California. She's going to speak about execution, tips and tricks for toric surgery techniques.
Hopefully everyone can see my slides okay. Thank you so much, Dr. Ambati and to Orbis Cybersight for inviting me to speak. So I'm going to talk a little bit about now the execution of astigmatism management, specifically some tips and tricks that you can use for toric IOL surgery. And these are my disclosures. So why do we even care about getting that toric IOL perfectly aligned? So Dr. Hu alluded to it earlier. This is a nice table that tells you more specifically what to expect when you are misaligned. So every 1 degree of misalignment of the toric IOL leads to about a 3.5% undercorrection of the patient's astigmatism. So that means that if you're off axis by 10%, you are uncorrecting that astigmatism by 35%. And once you are off axis by 30 degrees, you're essentially canceling any astigmatism correction altogether. Obviously, even greater degrees of misalignment can cause you to induce worse astigmatism than the patient even started with. So it's extremely important to make sure that that toric IOL stays where you want it to. So overall, there are 3 steps for successful toric IOL implantation. You want to be able to identify and locate a horizontal reference axis. And then during surgery, you want to locate that steep axis where you want to align the toric IOL. And then obviously, finally, you want to make sure that you properly align that toric IOL along the steep axis and make sure the IOL stays there. So conventionally, when we're making those pre-operative reference marks, you can do this manually just by simple visualization. Have the patient sitting up, and usually I have the patient have both eyes open, looking in the distance over my shoulder. And what that does is it prevents the patient's eye from converging. And it also will allow for the patient to be looking straight without any cyclorotation of the eye, because we know that when patients lie down, the eye tends to cyclorotate, and it can throw your axis off. Most patients have over 2 degrees of cyclorotation. Some patients have even more. So whatever you do, make sure the patient is always looking at a distance target and they're sitting up when you're doing these marks. You can also use a slit lamp, and you can just use a horizontal beam of light to increase the accuracy of where you place those 0 and 180 degree marks. And conventionally, we can then take the patient into the OR, and when they're lying down, we're going to use a toric axis marker to line up to the 0 and 180 degree marks that we made, and we make a 3rd mark at the steep axis, which is where we want to align that toric IOL. So that's the traditional method. But of course, now we're living in a digital age, and so almost everyone has a smartphone these days. And what is it that a smartphone can't do these days? So every smartphone has a gyroscope integrated. And so what this allows is that we can actually hold the phone using the camera setting in front of the patient's head and make sure that the patient's head is actually properly aligned and level. And so that better assists us to mark those 0 and 180 reference marks with greater precision. The other thing that this app can do, and there are many different toric IOL apps available now, is that it allows you to take a picture picture with the overlay of an axis marker so that you can even line it up to a landmark on the patient's eye, for example, a nevus or a prominent blood vessel, and it will automatically calculate the angle between that landmark and the steep axis where you want to align the toric IOL. And then you can take that picture intraoperatively and use that to guide the alignment while you're doing surgery. So potentially you don't even need to mark the patient at all manually, preoperatively. So many companies have taken this to the next level and incorporated digital visualization for better toric IOL alignment. So in these cases, you don't need to mark the patient at all. And that's because if you take a reference photo with the patient again sitting up, the software will identify the limbal blood vessel anatomy of the eye, and it can determine the reference axes based on that, so that when the patient lies down on the bed under the microscope, it can compensate for cyclotorsion and know exactly where the 0 to 180 axis is, and it can overlay an image in your microscope that tells you where to align the toric. So in that bottom right corner, you can see the yellow line is where the 0 and 180 axis is based on the patient's limbal blood vessels from where they were sitting up. And then the blue triple line is the steep axis of the corneal astigmatism and where you should align that IOL. So it has increased precision, exponentially in many cases, thanks to digital marketing. And then Dr. Hu spent a lot of time talking about intraoperative aberrometry. That's another method of helping you to choose the correct toric IOL power and also to properly align it during surgery. And this is an aphakic refraction, so you do need to make sure that the eye is at the correct pressure, the ocular surface is well lubricated, and the patient is fixated at a light. And so many of these factors can be difficult to control. So sometimes it can be difficult to get an accurate reading, but obviously if you're an experienced surgeon like Dr. Hu, you're going to get even more precise outcomes. For me, I don't use intraoperative aberrometry. It's not necessary or mandatory to get excellent outcomes, but it can be helpful in many situations, especially post-refractive cases in which IOL calculations can be a little bit less precise. So this is actually the method that I use for toric IOL alignment. In my practice, and I'm in Southern California, I'm actually doing femtosecond laser assisted cataract surgery on all of my cataract patients. And the femtosecond laser that I use has iris registration built in which again, you take a preoperative reference image, and instead of looking at the limbal blood vessels, it's looking at iris landmarks. And so when the patient lies down again under the laser, it's able to compensate for cyclotorsion, and it identifies visually the steep axis by making these little notches or tabs in the capsulotomy. So when it makes the circular capsulotomy, it leaves the notches right at the steep axis. So in the OR, you can see under the microscope exactly where those notches or tabs are, and that's where you want to line up the toric IOL. And it's great because it can also show you very easily post-operatively if an IOL has rotated, because it will no longer be aligned with those little tabs. It's also great for more precisely creating the arcuate incisions or the AK incisions at the precise axis, as well as the clear corneal incision. I program it to be around 10 degrees in the left eye and 10 degrees in the left eye and 190 degrees in the right. I had to think about that. So that every clear corneal incision is made at the exact same diameter, depth, and axis, so that I can really standardize and uniform my SIA. So here is a live video of a case I did a few weeks ago. It's a brunescent cataract with against the rule astigmatism. And you can see the femtosecond laser makes that capsulotomy with those little notches or tabs at that 0 to 180 against the rule axis. And then obviously it helps to fragment the very dense nucleus, and which greatly assists me in surgery when disassembling that nucleus. And it makes that clear corneal incision as well at the same place, same depth every time. This is a separate case. So we all know that with multifocal IOLs, it's even more important to correct astigmatism, because a little bit of residual astigmatism, even as low as 0.75, can greatly degrade the patient's visual quality. So this was a trifocal toric IOL case, and you can see how beautifully the preoperative plan matches the final post-operative result. And it's a little hard to see, but you can see that little tab in the capsulotomy, and you can see that that toric IOL is perfectly aligned where I want it to be. And so it's no surprise that there are many studies showing that digital markings offer a, even higher level of precision. But I think if you even just do very good and careful manual markings with the patient, fixating at a distance target, you can still get a great outcome. So it was interesting that Dr. Vaishali did her poll and showed that about 20% of the viewers right now currently are not using a toric IOL. So I'm just going to show this basic surgery video on how to insert and properly align a toric IOL. So you can see here, let me see. It's a little bit difficult to see, but this is a post-RK patient. And okay, so there's this little tab here on the capsulotomy. There are the two tabs right there. And so I'm using a toric IOL in this post-RK patient. Now, I have made sure that the astigmatism here is regular and consistent. So I did 2 topographers, 2 biometers, and it was all in agreement. So surprisingly, this patient had relatively regular and symmetric astigmatism that agreed on 4 different devices in terms of magnitude and axis. So I was very confident in planting a toric IOL in this case. So topography is essential to make sure that the patient's astigmatism is regular and a good candidate for toric IOL implantation. So here I'm injecting the IOL, and you'll see that what's important here is I'm actually leaving the IOL slightly under rotated. So the tab is right here. This is the mark. So I'm leaving it slightly counterclockwise because I know that when I remove the OVD, the lens tends to rotate clockwise. So you can see I've left it slightly counterclockwise. And when you go in with your INA tip, what's important is that you remove all the viscoelastic, and that's what's going to minimize post-operative toric IOL rotation. And so you want to get all the viscoelastic on top of the lens, but also behind the lens. And how do you know you're getting it behind the lens? You see the lens just jumped and jiggled there. That's how I know that I got all of the OVD behind the lens. You can also gently go under, but I find that I don't need to when I use this technique of gently tapping on the lens. Then I just go to the optic haptic junction of the lens and gently nudge those toric markings towards the axis of the intended alignment. And there I'm pretty happy that the IOL is where I want it to be. And so I go ahead and end the case and seal the wound. So just a summary of my pearls. You want to make sure that you're implanting it slightly counterclockwise from where you want it to be. And after removing the OVD, you want to use the IA tip to nudge that optic or that toric IOL into the proper axis. So in order to minimize post-op rotation, again, remove all of the OVD, viscoelastic. You can push gently on the IOL to get all the viscoelastic from behind the IOL. Use a cohesive viscoelastic when you are inflating the bag, because if you use a dispersive, it's going to be really difficult to remove that viscoelastic. The cohesive viscoelastic is a lot stickier and larger, and they tend to come out more easily in clumps, and it's easier to aspirate out. As Dr. Ambati mentioned, you want to under pressurize the eye at the end of the case, because that allows the capsule to better hug the IOL and to minimize postoperative rotation. As Dr. Hu mentioned, do extensive polishing. I actually use a shepherd's hook, a separate instrument, to completely polish underneath that anterior capsular rim. And actually, studies have shown that the most common reason for postoperative IOL rotation in the late postoperative period is due to capsular phimosis and bad contraction. And that's because you're not cleaning off the lens epithelial cells. Most commonly, though, what we see is that if any rotation is to happen, it usually happens within the first hour to 10 days post-op, and that's because of retained viscoelastic. Finally, a final point. You'll find that in some eyes, it is difficult to keep the IOL where you want it to be. It tends to rotate. And this usually happens in highly myopic eyes with large bags. And so in those cases, you can consider inserting a CTR or capsular tension ring to mechanically keep the toric IOL in place. And that's happened to me before. I kind of learned that the hard way. I used a CTR because I noticed there were some loose zonules and I wanted to increase bag stability. And then when I inserted the toric IOL, I didn't rotate it quickly enough. And when the haptics unfolded, it actually became very difficult to rotate with that CTR in there. So if you place this, make sure that you rotate quickly before the haptics open, but it definitely adds to IOL stability. And then the other thing you can do is actually, in rare cases where you're going back in to realign the IOL, but it continues to rotate, a nice way to make sure that it doesn't rotate again is just to reverse optic capture the IOL. So that just means leaving the haptics of the IOL in the bag and popping the optic above the capsule. So that's kind of a neat trick to use in rare cases where that toric IOL does not stay where you want it to. So what happens if you have a patient with residual astigmatism post-operatively that's, a surprise and unexpected? First of all, you want to make sure if the toric IOL rotated, is that the cause? And it's really easy to see when you have the capsulotomy tabs whether the toric IOL rotated, but sometimes it's not that easy to tell. And so astigmatismfix.com is a great website to help you figure that out and also guide you on how you should rotate the IOL. So you basically just input all the data that you have in terms of what type of lens you placed, what power it was, what the toricity was, what was the IOL axis you were aiming for, and what's the current IOL axis, which the lens is sitting at now. And then the most important part is entering the patient's current refraction. So you can see that this patient has residual 4 diopters of astigmatism. But what's important is that the spherical equivalent is plano. And so that means that potentially you could rotate the lens to cancel out the astigmatism. If your residual spherical equivalent was -1, +1, a rotation of the lens is not going to help you. You're better off exchanging that lens to get a better, more accurate spherical power. So we input all that information, and then the website actually tells you, well, if you rotated this lens 40 degrees clockwise, you would be able to minimize the astigmatism. But we actually can't get it to a point where the astigmatism goes below 0.75. So in this case, they're actually recommending that you exchange the lens probably for one of higher toricity that would better be able to correct this patient's residual astigmatism. So a super helpful calculator and tool that you can use to figure out how to fix your patients with residual astigmatism after toric IOL surgery. So really quickly, what about LRIs and AKs? So I know there are parts of the world where you may not have access to toric IOLs or patients may not want to pay out of pocket for it. LRIs and AKs are still a great option for astigmatism correction. And the main difference is that LRIs are placed more peripherally at the limbus, whereas AKs are created more centrally, usually 8 to 9 millimeters in diameter. And the great thing about AKs is that you can create it with a femtosecond laser. And that's what I do because it offers greater precision and stability. So what's important to note is that any arcuate incision is always going to have greater effect in older patients. So you can use shorter arc lengths in older patients and longer arc lengths in younger patients for the same amount of correction. Really, really important to avoid any arcuate incisions in irregular eyes with underlying ectasia or keratoconus because you risk further destabilizing that cornea and causing worsening irregular astigmatism. And both are still less predictable and less stable than a toric IOL. So I would still use a toric IOL if a patient has a minimal level of astigmatism and if that is available to you. So here's a poll for you guys. What is your preferred method for managing with the rule astigmatism in a cataract patient with 0.75 diopters of cylinder? So this is similar to Dr. Hu's question, but I believe his case was against the rule. This is with the rule, okay? And remember, in with the rule astigmatism, we tend to undercorrect a little bit. So this is a very small amount. So what are your options here? Would you perhaps operate on axis, create a manual LRI or AK, do a femtosecond laser LRI or AK, implant a toric IOL, tell a patient they'll need postoperative laser vision correction, tell a patient they need glasses or contacts, or there's really no special correction needed for this patient because it's such a low amount. So, take a few seconds to vote here. All right, so as expected, it's kind of dispersed throughout, but it looks like the most common answer is operate on axis, followed by using a toric IOL, and no special correction is needed. So for me, I think that operating on axis is a perfectly good solution because, like I said, it's a very small amount of astigmatism. There's really no toric IOL available that will correct that low level of with the rule astigmatism. So I would not implant a toric IOL. I do think an LRI or AK is a good option as well. And for those who answer no special correction needed, I think that's okay if you're implanting a monofocal IOL. But remember, when we are placing our incision temporally, we're actually worsening the width of rule astigmatism as well. So you could potentially be causing 1 diopter or more of width of rule astigmatism. So that can be significant even for monofocal IOL. So I would say I would still try to correct this low level as much as we can to get patients the best outcome possible, especially for multifocal IOLs, but even monofocal. So we actually asked this question as part of ASCRS in the United States back in 2019, and these were the surgeons' responses in the US back then. And you can see that the majority chose on-axis incision operation, but still 17% said that no special correction was needed. So I think there's still some education, even in the US, about needing to manage even low levels of astigmatism. So based on this data, when should we be using arcuate incisions versus a toric IOL? You can use these tables as references, but for me, I tend to use a toric IOL for against the rule astigmatism 0.75 diopters or greater. That usually corresponds to a T3. And I'll use toric IOL for with the rule astigmatism 1.25 diopters or greater. And again, that's because of the posterior cornea. It tends to give patients greater amounts of against the rule astigmatism because of that against the rule posterior cornea astigmatism. So that's why you always overcorrect against the rule and undercorrect with the rule. And for anything less than that, I'm using my femto-AKs. Really, I'm not using femto-AKs for anything greater than 1.25 because I've noticed rare cases where if you're making arcuate incisions above 1.5 even, and because it's so much more central, those corneas can destabilize over time. And so I try to minimize arcuate incision length whenever possible and go to a toric IOL. So this is just the prevalence of astigmatism worldwide. And you can see the majority of eyes have low levels of astigmatism, less than 1.5, but even a large portion of those patients can do well with a toric IOL, especially with those, again, with against the rule astigmatism. But you can also use arcuate incisions depending what is available in your part of the world and still have an excellent outcome. So additional pearls, we've talked a lot about SIA. Make sure you track it. If it's a small incision, it's usually negligible. For me, it's about 0.1. Always make paired arcuate incisions rather than a single large one, again, to avoid destabilization of the cornea. And you can even pair toric IOLs with arcuate incisions to treat cases where you have higher levels of astigmatism. So on the majority, I think our toric IOLs in the US, they basically correct a maximum of 4 diopters of corneal astigmatism, but multifocal IOLs, they correct only up to 2.5. So on that bottom right image there, I have a trifocal lens. So I'm pairing the toric IOL with AKs in order to correct astigmatism in that patient that's greater than 2.5. And on the left-sided image, I believe this is a case of a highly myopic eye. I had to use a very low-power 3-piece lens, which did not come in a toric option. And you can see that I paired it with femto-AKs to correct the astigmatism in that patient. A quick note on operating on axis. So most surgeons now are doing a temporal phaco incision just for easier access and because it's not as central because the patient's horizontal diameter is wider than the vertical diameter. So it actually minimizes your SIA. So remember that for against the rule patients, if you're operating temporally, that's great. It's going to reduce their against the rule astigmatism. But for your with the rule astigmatism patients, operating temporally will actually worsen that with the rule astigmatism. So it's something to keep in mind. Typically, it can do so up to 0.5 diopters, but it's a great technique to use if you do not have a toric IOL available, arcuate incisions are not possible. So you can actually even do a pair of clear corneal incisions on axis to potentially reduce the patient's astigmatism up to 1 diopter. So something to keep in mind. So really quickly, some of our next speakers are going to go over the different types of IOLs that you can also use in more complex astigmatism situation. but we live in a great time today where there are so many different IOLs available for different astigmatism scenarios. Here I'm using a small aperture pinhole IOL for a post-RK patient with irregular astigmatism, and that is great for correcting irregular astigmatism. Even up to 1.5 diopters of refractive astigmatism, it will null that because of the pinhole optics. And then on the right, I have a post-intact keratoconus patient. I like to use a zero aberration monofocal lens whenever possible to not further worsen aberrations in that eye. And so that is my toric IOL of choice for cases like those. So in summary, use a toric IOL whenever possible. There are many steps you can take to maximize precision and stability of the toric IOL, and your patients will thank you for it. So thank you so much for your time, and I'm happy to answer any questions.
Thank you so much, Dagny. I think we have time for just one question. What's your preferred technique for toric marking?
So for toric marking, so if I'm doing manual toric marking, I use my slit lamp with the horizontal beam, have the patient have both eyes open, looking at a distance target over my shoulder, and I will set it as 0 to 180 and I will mark it manually. But in most cases now I'm using iris registration with my femtosecond laser, so no marking is required. It will automatically identify the 0 to 180 and make those little capsulotomy marks for me.
Our next speaker is Dr. John Doan, and John will be sharing with us his experience on the light adjustable lens and Bioptics.
Great. Thank you, Bala. Really a pleasure to be with you all this morning. I really want to thank a couple of people that helped out in this presentation. Certainly thank Bala for the invite, but Andy Chen and Lawrence Seca, who with CyberSight have just done a wonderful job setting the stage for everybody. So what I want to go through today is a couple things. I'm going to just a slide on toric IOLs, a slide on Bioptics, but I'm going to spend the most of my time on the light adjustable lens. And as the speakers have mentioned this morning, and effectively over the last 30 years, we've had 3 approaches to treating astigmatism: incisional keratotomy, laser vision correction, corneal laser vision correction specifically, and then IOLs, toric IOLs. I'm maybe a little bit different than most of the speakers. I essentially abandoned corneal incisional surgery for astigmatism about 10 years ago. I just found that IOLs and excimer laser were just so far superior. And the reason I say that is that the stability of the correction. And I just over time, so many patients where maybe I was treating 2 diopters of astigmatism, and I followed them long enough and found out that the 2 diopters I treated that was with the rule over the course of 10 years was now 2 diopters against the rule. So I've kind of backed away from incisional keratotomy, just feeling that the stability of either treating the astigmatism with the toric IOL or with laser vision correction was superior, and I can treat really small amounts of that. So I felt very comfortable in that sense. So I do apologize, maybe a little bit different than the other speakers, but again, would be interested in their thoughts on what I was just saying. So let's go through a couple of things. I am a consultant for Carl Zeiss in ArcSight, and these would be probably two places that would be some crossover in this talk. So the light adjustable lens, the technology is certainly leading edge, and we'll get into why I think that is a case here in just a second. It is not brand new. The light adjustable lens has been, at least in concept, prior to the year 2000. I got involved with the company in 2008 as an FDA investigator and went through all of the different trials for both spherical and astigmatic corrections and things that are still coming to market over the last few years. We've been doing commercial cases now for 5 years in Kansas City, starting in June of 2019. And really the concept is the following. We place the lens in the eye, and then we adjust whatever residual refractive error is present in the refraction of the patient. In addition, we determine where we want to target that patient with the patient's input. Are we going to do both eyes for distance? Are we going to do one eye distance and maybe one eye for near? The one great thing about the light adjustable lens is there's built-in extended depth of focus, and so we can achieve excellent distance and near vision with very small amounts of residual refractive error in the quote-unquote near eye. And I would say the vast majority of patients we treat, the near eye is still legal driving. And so the adaptability to this process is much better than what we experience with either LASIK or monofocal IOLs, where maybe 30% of the patients will not tolerate the difference in power between the two eyes, i.e. the anisometropia. And what we're doing with the light adjustable lens, the adaptability or the tolerability is probably 98 to 99% of eyes or patients. So only 1 to 2% of patients may say, hey, I really cannot tolerate this. I need both eyes at the same focal point. So where are we with current IOLs? I would say that a third of the patients that we treat have a residual refractive error of 0.75 diopters or more, and another third probably have residual cylinder of 0.75 or more. And that's when we're treating, let's say, a spherical monofocal IOL. So 2 out of 3 IOL patients have imperfect distance vision. When I say perfect, I'm talking about 20/20 distance vision. I found out that patients are not 20/20. They tend to complain of 3 things: inability to see road signs and highway signs as quick as they'd like. And let's say if they're watching TV or watching sports, seeing the scroller on the TV, reading names and numbers on jerseys on TVs, or reading the score on a TV. So a patient was 20/20, they go to 20/25, they now come and complain because they can't see those things. And at that point, I know that they're not 20/20. So it just puts a premium on getting people to literally perfect vision so they will not have those complaints. So what about multifocal IOLs? What issues arise there? Well, there is somewhat imperfect distance vision because the quality of vision is not as good as in a monofocal optical setting. And if you're doing multifocal IOLs, you're actually guaranteeing halos for virtually every patient, and there's some variability in what patients will complain as far as glare. Reading vision, it can be mediocre, and I wish I could say it's perfect. It certainly is not. Maybe 60% of people love their near vision, but the others are just kind of, even though they're J1, they're kind of, not so good. And then a defined number of these patients need laser vision correction to enhance their distance vision. Because again, if they're not 20/20, they're going to complain that they can't see things quite like they like. Again, road signs, highway signs, scroller on TV, scores on TV, names and numbers on jerseys on TV. So how successful are we? Well, for my monofocal bilateral distance patients, what percent want glasses for better vision? Again, I think this is probably at least 30%, because just a little bit of astigmatism will lead to those problems, as I just mentioned, as far as those vision things in our activities of daily living that they're having difficulties with. So what about targeting and planning surgery? But all the other speakers have kind of walked through this, all the different tools they use to get the best results. And not uncommonly, it's multiples of these. So it's multiple ways of measuring the cornea, be it auto Ks, manual Ks, IOL master, and then axial length. Are we measuring it by IOL master, pentacam? Are we doing immersion? And then are there multiple formulas it might use? So I have one of my partners historically has done like 5 different keratometry readings. At some point, you have to pick up which one's the most accurate. I find that a little bit perplexing that you have so many variables in this equation trying to pick out which one's the best, what's the best formula. So it really adds a lot to the decision-making and selecting the lens that you're hoping will get the person to the target refraction. So how does that light adjustable lens work? Well, in effect, you're going to put the lens in, and at some point postoperatively, we're going to either add or subtract power from the optic. And we can do this by creating plus or 2 minor diopters of spherical correction change, and probably up to 2.5 diopters of astigmatic change for those patients in the refraction. I will say also that this number is going to go up. The company is going to have a base toric lens, maybe sometime in the year 2024, where you can start with 2 and then you can adjust an additional 2.5. So we can probably get up to about 4.5, maybe 5 diopters of correction for some of those patients that will need that higher corrections. At present, with the 2.5 diopters, I only put in 5 toric IOLs in the last year, because all the other patients I saw, I could correct their astigmatism with the light adjustable lens. So it's a smaller number, but there are some patients that will certainly benefit from the hopefully soon to be available technology from RxSight. So what does the lens look like? It is a typical 3-piece lens, foldable silicone optic material. The power range is from 4 to 30 diopters in power. And we're going to implant the lens just like a typical patient for any other surgery. We're then going to come back post-operatively and make a determination of how to adjust that patient. What's the process and how does it work? Well, the lens itself is the following. There are essentially three elements within the lens. There's the polymer matrix, which you see here in green. There are free-floating macromers that disperse within the lens, and these blue dots are photoinitiators. The bottom line is, as these are freely movable, the macromers, it can change the three-dimensional shape of the lens. And we're going to see how that works on the next slide. So effectively what you do is when we're adjusting the refractive power, we're going to place light over the lens, and we may do this asymmetrically. We may decide we want to put more light in the center of the lens. This will cause some photopolymerization in the central lens, and this will allow these free-floating macromers in the pink to migrate to the center of the lens. As they do, they will increase the radius of curvature of the lens, or decrease the radius of curvature of the lens to correct hyperopia. We can obviously do the reverse if we need to treat myopia. So once we're where we want the patient to be as far as power, we can then lock that power into the lens and keep that refraction stable long term. So this is adding power to the lens. I've kind of at least discussed this in the last slide, but let's go through it again. So if we concentrate the light or photons in the center of the lens, this is going to cause migration of the free macromers within the lens to the center of the lens, decreasing the radius of curvature, treating hyperopia, and getting the patient to a plano sphere refraction. On the opposite, if the patient is myopic, we need to flatten the center of the lens. So we're going to put light out in the periphery of the implant, going to cause migration of the free macromers to the periphery, flatten the center of the lens. We're going to lock it in place, and we're going to take a person from a myopic refraction more towards zero or plano. And if they have astigmatism, we're just going to do this asymmetrically across the major meridian. So the LAL procedure essentially occurs what we see in slide right. So we have a light delivery device, we have a contact lens to fixate to the cornea, and this is what the surgeon is going to be looking at. A ridicule with behind, they're going to see the outline of the lens. Patients will undergo conventional cataract surgery. No sooner than 17 days post-op after the second eye is implanted, the patient will be refracted, dilated, and then submitted to the light delivery device. So they're going to be seeing blue light. The treatments last anywhere from about 40 seconds to 150 seconds time for the patient. That is per eye. We typically will do both eyes same day. The average patient is the following: a single adjustment, day 17, locking in the patient at day 21, and then having them back 3 to 4 days later at day 24 for their second lock-in, and they're finalized. About 50% of the patients need more than one adjustment, so they may go out to day 27. So adjustment on day 17, adjustment on day 21, lock-in on day 24, and final lock-in, second lock-in on day 27, day 28, they're done. These can be extended. They don't have to be definitive on those times. We've had patients, for example, that have had they've had incisional keratotomy, radial keratotomy. We may not start their adjustments until 8 weeks out to make sure that the cornea is a stable condition before we start basing our treatments on what we think is the stable long-term refraction. So this is what the patient is going to see. They're going to see the ring light. They're going to fixate on the green fixation light. We will then place the contact lens, and then the surgeon is going to see the following. You don't see the outline of the lens behind this, but what the surgeon is going to be looking at is this reticule and lining this up with the periphery of the lens 360 degrees at the time. What do I consider? So kind of moving ahead, I think that the light adjustable lens is essentially an ophthalmic eraser. So whatever you do on your pre-op, let's say your biometry is off, or, heaven forbid, you don't have the exact power lens you need. This allows us to basically look beyond all the things, all the variables that you have to work with biometry, keratometry, getting the surface just right, that we can come back with the light delivery device and do true fine tuning of the refraction. And it really boils down to the following, that if you're not on power and the patient's not happy, what do you do? Well, we've talked about a few of these already, with docs talking about, do you do an arcuate incision? Do you do additional laser vision correction? Do you do an LRI? Do you do a lens exchange? Well, with the light delivery device, we basically can avoid all that. And as I call it, the easy button. We just bypass all those questions and come to the adjustment of the lens with whatever power is left after they've had implantation of the light adjustable lens. So these are crazy cases. In the past, I might try to give a patient expectations that they might be spectacle free after they've had incisional keratotomy. I did this early in my career, but about probably, maybe 10, 12 years ago, I finally said, I give up. Any patient that's had incisional keratotomy, I would just tell them, you will be in glasses for everything, distance, intermediate, near. That changed, 5 years ago when we got the light adjustable lens, that I started becoming comfortable, and we treat these patients with the light adjustable lens. In the past, no, but now we're back to this is really an easy button. As I mentioned earlier, we do wait approximately 8 weeks for these corneas to get stable before we start the refraction and the adjustment process for these patients. So what about difference in outcomes? And there are 2 slides I'm going to show, at least comparing a toric implant compared to the light adjustable lens implant. So as the previous speakers have talked about, you have to get the most accurate measurements possible as far as what is the astigmatism on the cornea, select the lens, and then hope you land on target. Well, this is data from Alcon looking at what percent of patients get to 20/20. This is about 38% of patients with the Acrosoft toric lens got to 20/20 versus almost 70% with the light adjustable lens. And this is the first iteration of what we were doing with the light adjustable lens. Subsequent, we found out, again, Alcon toric at 38%, and with the light adjustable lens, now we're at 86%, seeing 20/20 or better after adjustment. Again, we're treating anywhere from, let me take a step back. The laser will adjust 0.5 diopters of astigmatism at a minimum. And again, we're going to maximally treat probably 2.5 diopters of astigmatism. So toric IOLs, we know that at least 30% of eyes have 1 diopter or more corneal astigmatism. So again, as Dagny and Jerry had talked about, they're going to attack 0.75 or 1 or certainly more. But what do we do with those people that have less than? That was kind of part of Dagny's talk. I feel totally comfortable with the light adjustable lens going after those. We know that you have to treat that half a diopter. You have to get the patients under half a diopter for them to not have complaints, as Dr. Vasavada said, as far as quality of vision and contrast sensitivity. So I think it really is important to treat the astigmatism, as everybody's mentioned, and get it as low as possible. I just know that the accuracy we have with the light adjustable lens is better than I have with torics, and thus the reason I tend to default to the light adjustable lens for any patient that I have concerns of astigmatism being an issue for them, affecting their best unaided vision post-operatively. Bioptics. This is essentially my last slide, talking about what in the world is this? Well, with bioptics, we're using both the cornea and the intraocular lens to correct refractive error. There's only a couple select places where I use it at this point. In the past, when we were doing, let's say, the STAR ICL or intraocular contact lens, in the US, we only were able to treat sphere. So if patients came in with astigmatism, we would debulk the myopia with the ICL and then come back with laser vision correction to correcting a residual astigmatism. So this was probably the best early example. Now with large ametropias, sometimes we do have to adjust them with an IOL. That could be with the LAL or otherwise. And where we see this commonly is people with incredibly large ametropias and astigmatism. We may put in a posterior monofocal or toric IOL and then put the light adjustable lens in front of that. And if by chance there's any residual astigmatism, you can come back on the cornea with laser vision correction to remedy any residual refractive error. Again, that being astigmatism or even small spherical error levels. So this is my question for everybody, and we'll get an answer. The light adjustable lens is A, a phakic intraocular lens, B, accurately corrects sphere and astigmatism, C, the optic is made of hydrophobic acrylic material, or D, does not have to be locked in after implantation. And so what we have here is that which is correct, B, that light adjustable lens accurately corrects sphere and astigmatism. That is the end of my talk. Bala, I don't know if there are any other questions from the audience. I'm more than happy to answer.
Yes, there's quite a few questions. I think you have a very popular presentation, John. Thank you for joining. Over the years, will the LAL change power or astigmatism after contact with sunlight?
So there are two, the original version that we had in the US, there were some patients that did change. I'll try to explain that. We would do the adjustment. They would be locked in, absolutely perfect. I might see them a month after their adjustment, everything just spot on, planosphere, love and life. They might come back at 3 months later and all of a sudden, wait a second, now they're a minus 0.75 in 2030. So we did have some people that, let's say, it wasn't long-term, it was actually, within 3 or 4 months after treatment, they did migrate. About 3 years ago, RxSight came out with a version of lens called Active Shield. That was part one. The Active Shield blocked out any external UV light that could possibly change the power of the lens before lock-in. In addition to Active Shield coming about really from a safety standpoint, the lock-ins changed, much more robust. Since that time, I have not seen people migrate. So we've had 3 years of Active Shield plus a very, what we call robust lock-in period. I have not seen migration since that time. That being said, I learned a long time ago, never say 0% or 100% in medicine. There may be patients at some point that they could get a year or two out and say, gee whiz, they're off a little bit. We need to do something. I think that's going to be very uncommon going forward based upon what I just said and the changes that RxSight made. So yes, things can change. And maybe one of them too, is Bala, is that we know that certain people over time with gravity, with blinking, may go from a certain amount of with the rule astigmatism to less with the rule astigmatism, or go from planosphere to against the rule astigmatism, or more against the rule astigmatism. So I would never rule that out over the course of decades from that standpoint. That would, in my mind, that would not be an IOL issue. That's more of a corneal issue.
Yeah, indeed. Patients do have some drift in against the rule astigmatism over the course of their life. Some more LAL questions. Can we modify spherical aberration with the LAL? And what size incision do you use with the LAL?
Yes, there are certain that I think we're probably past the first inning to use a baseball comparison, 9 innings in a baseball game. We're probably in the second inning. There are many different things we can do with the light adjustable lens. I think that the next thing, as I mentioned, adding a base toric so we can increase the amount of astigmatism we can treat. We project blue light on the lens, you literally can do anything you want. You can add EDOF. You could add let's say a bullseye in the center of the lens to get greater near vision. You could, if you wanted to do something customized as far as a wavefront pattern, I think that's all possible. And RxSight they have done certain things that they've not released. And I'm sure their research team has all different things they could do. Now, getting out of the first few innings is obviously treating sphere, it's treating regular astigmatism, and they're doing a great job. Now just adding to the astigmatism pattern. So I think the sky is the limit, and we're just kind of scratching the surface, as they say, of what the technology possibilities are.
What's your current strategy as far as optimizing EDOF, extended depth of focus, with the LAL?
Yeah, so I didn't really have time to get into too much depth. There are 2 lenses available from RxSight right now. There's the base lens that has about 0.75 diopters of EDOF with the adjustment. There is a second lens called the LAL Plus lens that comes with about 0.5 to 0.62 diopters of built-in EDOF. So I kind of alluded to this at the beginning, that in the near eye, we don't have to be a -2 refraction to get J1. Many of these patients can be -0.75 or -1, and BJ1, yet they're 20, 30, maybe even 20, 25 at distance. So they have legal driving vision, but incredibly good near vision. So probably 90% of the patients we treat will have one eye distance, or let me take that back. Almost every patient we treat has some level of minus power in their non-dominant eye. With that being said, 95% are 20/20 at distance, and probably 95% or thereabouts are J1 for reading. There will be some people that want to be a little bit sharper. They can always put on reading glasses, but we effectively even gotten to spectacle independence for the vast majority of patients, and not having the anisymmetropic effects of true monovision, where one eye is plano and one eye is, let's say, -2 or so.
Perfect. Do you use the LAL to rescue patients who've had bad experiences with multifocals in the past?
Absolutely. So I would say every month there's probably 2 or 3 patients that coming from doctor elsewhere. I just looked at some of my data from last year. I think I did 3 multifocal lenses. And the reason I did those, one person, I'd done a multifocal on the Panoptics 4 years ago. A second person was effectively one-eyed and wanted both eyes had effectively one-eyed, so needed that eye to see all focal points. Other than that, I essentially do the light adjustable lens, and we see a fair number of patients that simply cannot tolerate multifocality, the quality of vision. So we will exchange, and they will do really well. With our scenario, again, we have to tell them that you're not going to get 3 focal points out of one eye. You're going to get 2+. Some people do get 3, but expect 2. With 2 eyes working, you should get all 3.
And are you using LAL in both post-myopic LASIK and post-hyperopic LASIK patients?
Yes, absolutely. So the company line is to use the straight LAL in the hyperopic patients and not use the LAL plus, where we're increasing EDOF. I have used it in those patients, and I can't tell that they have any negative impact. So absolutely, I use it. I mean, it really is my go-to lens for all patients, but it's an absolute game changer for anybody post laser vision correction, anybody has liked monovision in the past, anybody that's had incisional keratotomy and wants to be relatively spectacle free, and then just the standard patient that wants to not be in glasses. It's just, in my mind, just a godsend. It just, again, as I talk about it, it's kind of our magic eraser. It resolves all of those issues that can affect a person's satisfaction or happiness with their unaided vision.
Terrific. Thank you so much. Appreciate your overview on the LAL. My talk is on managing astigmatism with complex corneal situations. So the challenge of corneal irregularity is that we have difficult intraocular lens calculations. That being said, patients who've had prior corneal disease, keratoconus, or prior corneal surgery such as radial keratotomy, they're long-suffering patients, so they tend to be very grateful for any improvement in quality of vision. So it's both a challenge and an opportunity. So I'm going to share a couple of cases. One patient had keratoconus when he presented for his cataracts, and what you can see on the topography is this inferior steepening, a lot of asymmetry on the cornea, as well as posterior elevation. And this was on 2 months after treatment with Intact. So you can see that the amount of corneal asymmetry and steepening was reduced by placement of an intracorneal ring segment in the infratemporal cornea. Similarly, with the left eye, which was worse, the keratoconus was steeper, I also placed an Intact, and we were able to dramatically decrease the corneal asymmetry and the corneal steepening. So my approach here was to treat each eye with Intacts, and then once the cornea had stabilized, to put in TrueLine lens. The TrueLine is a crystalline platform. It has hinges that allow it to move. It's a zero spherical aberration. And once the cornea was normalized by Intacs, I was able to treat the residual astigmatism with the TrueLine IOL. So the outcomes with a staged procedure, we were able to dramatically decrease the asymmetry on each eye with the initial surgery of Intacs, and then after the second procedure, removing the cataract and placing a TrueLine IOL, we were able to achieve a very nice outcome for this patient. Second patient that I want to discuss is somebody who had prior multiple corneal procedures. Back in the 80s, they initially had ALK, radial keratotomy, arcuate incisions, so a lot of prior corneal surgery. And I'm going to initially start with some general pearls that I use on post-RK management. I think it's very important to use topography, tomography to carefully analyze the central zone of the cornea and adjust your scale to really see if you can find a regular astigmatism there. Bring patients back at the middle of their waking day. So I ask my post-RK patients, when do you wake up? When do you go to bed? And I bring them back. We schedule an appointment to check the middle of their waking day. Be aware of what your limitations are. In the US, the monofocal toric IOLs can correct up to 4.1 diopters. The multifocal torics can correct about 2.6 diopters. The TrueLine goes up to about 1.8. I'm generally not going to do a PanOptix lens in more than 4 or 6 cut RK. And realistically, with the field going the way it is, multifocals in this population are going to be less and less common. The LAL is probably going to take over the management of post-RK patients looking for depth of focus. It's important to have piggyback lenses, PRK, and ocular surface optimization in your toolkit to manage the post-operative course of these patients. Lastly, axial length can affect toric effectivity. In long eyes, you may not get as much toric correction as you expect with a toric IOL. So this patient who I just described, who's had ALK, RK, and arcuate keratotomy, she presented to me with about 8 diopters of astigmatism against the rule. You can see this beautiful blue vertical bow tie, and she had 8.25 diopters by corneal Scheimpflug imaging. Slightly bit of long axial length. The optical biometry actually measured 9 diopters. So she had a lot of regular corneal astigmatism. So what I did for this patient was plan her surgery with Barrett True-K, and then I used 2 toric IOLs. So I placed one in the bag and one above it in the sulcus. I split the toric power 50-50. Each IOL had corrected about 4 diopters of astigmatism. I used a 6 diopter sphere for the piggyback, as that was the thinnest to place in the sulcus. And we used a CTR to improve the IOL rotation, IOL centration and rotational stability. So I placed a Tecnis toric as well as a MX60 ET. This has eyelets that allow rotation to be much more convenient. And this is the post-op image. You can see both lenses on top of each other. And conceptually, there's the primary IOL in the bag, and then the piggyback IOL, also a toric with the haptics in the bag and the optic above the anterior capsule. She did have some residual astigmatism, which I treated with PRK, and then 6 months later, she was 20/25 +2. So in conclusion, in other parts of the world where there are silicone plate IOLs, you can do double silicone lenses in the bag. In the US, there are no silicone toric IOLs. So in this patient, we used a piggyback toric IOL on top of a primary toric. In other parts of the world, there are customizable IOLs that go up to 12 diopters, but those are not available in the US. So, but this offers another option for patients with extreme astigmatism, where we can have a toric IOL in the bag and a piggyback toric on top of it. So I'll end with the video. Basically, the initial lens was the Technis toric going into the bag. And then on top of the that we put a piggyback toric, and then we're lining up the marks on both so that they're lined up. And then we used an Ahmed micrograsper to achieve that final optic capture where the optic is above the anterior capsule and the haptics remain in the bag. The micrograsper can hold the lens while Kugelin is used to move that superior optic edge anterior to the rhexis and achieve the optic capture. We then align everything, make sure that both lenses are in perfect position, that the lenses are well centered. And so here you can see the optic capture with the anterior capsule between the lenses, and then the marks of the primary IOL and the piggyback. So with that, I will end with a question. Which of the following are contraindications to astigmatism correction in cataract patients? RK, fuchs dystrophy, Salzmann's, rectal basement membrane dystrophy, or none of the above? They can all be managed or optimized prior to cataract surgery. So we'll let the vote take place. Should see the results momentarily. And indeed, the plurality said none of the above. And so, what I'd like to, leave the audience with is that, corneal disease should not scare you off from astigmatism correction. We can manage any of these conditions, fuchs dystrophy with DMAC, Salzmann's with removal, epithelial basement membrane with PRK or PTK, or superficial keratectomy. And all of these corneal challenges can be overcome to set the stage for correction with astigmatism correction. So that's it for me. We'll go back to the Q&A. Do I have any experience with LAL and keratoconus cases?
Absolutely. So we've had to do some effectively piggyback. So some of these patients, I can give a couple examples. Just in the last 2 weeks, I've had 2 different patients that I had to put in minus powered IOLs posteriorly and then put the light adjustable lens in front of it, because the keratometry is so high that effectively you would need a single minus powered IOL. So one of the patients, the posterior lens was a -10 J&J AR40 series lens. The other one, the posterior power lens was a -8. The anterior lens was the lowest powered light adjustable lens available. It was a +4. Now, neither one of these patients I've adjusted yet because they're not at the 17-day time period. So we'll come back and then we'll adjust them to wherever they need to be. Now, the caveat is, do they have irregular corneal astigmatism that may limit their best uncorrected vision? In this case, they both still had good, surprisingly, still had good uncorrected vision. So I'm hoping that at a minimum, they would refract to 20/20, and I'm hoping uncorrected wise, we can get them to 20/20. So in the past, I think this would have been very hard to do. You can still use, the keratoconus IOL calculation formulas, and then you obviously have to do some summation of the powers between the two eyes to try to get roughly to plano, and then adjust one way or another if you're off. So absolutely can be done. I've talked to RxSight, and they're hoping, as I mentioned earlier, the range of the light adjustable lens is +4 to +30, but they do think that they can have a minus powered lens. So maybe we could do these with a single lens at some point in the future.
Terrific. When you do the LAL as a piggyback, are you putting the LAL optic in the sulcus, or are you putting it in the back?
Yeah, great question. I put both lenses in the bag.
Okay.
So there's an acrylic posterior, silicone anterior, but both bags, all haptics in the bag.
Gotcha. So next question from the audience, I'll pose it to both Dr. Vasavada and Dr. Doan. What are your thoughts on using the IC8 Apthera for complex corneal astigmatism?
Yeah, I don't have any experience with that, but I think that it can have obviously a great role, and the more irregular the cornea, the more appropriate it probably is going to be. I mean, you may have some experience with that, Val, in your patients with irregular astigmatism from the incisional keratotomy. I can't imagine that it wouldn't be helpful. Dr. Vasavada?
Yeah, likewise. I don't have access to it yet, and so I can't say much, but it does sure look very promising in a lot of these irregular corneas. The only problem being a lot of these post-RK eyes also are high myopic eyes. So with the retinal evaluation, we just need to be a little careful with all these pinhole devices.
Yeah, that's
Yeah,
okay.
the only other option you have to neutralize that irregular corneal astigmatism that would push a person into needing a rigid contact lens would be to do a deep anterior lamellar keratoplasty. That would be an option to help resolve if as an alternative option.
Yeah, if you have a very aberrated cornea, just kind of start over with a new surface. Question for both of you. What are your recommendations if you are planning a toric lens and you have a posterior capsule rupture or anterior capsule tear? What would you do?
At least for me doing the light adjustable lens, you can still it's a 3-piece lens, so you can still put that lens in the bag. And you can also, if you could put the lens, the haptics in the sulcus and capture it with the anterior capsule. So you're not out of the woods with the light adjustable lens. You can still use it in those cases where you might not be able to use a 1-piece acrylic lens.
Yeah, I think I haven't used the LAL. I don't have access again. So if it's an anterior capsule rupture that does not extend beyond the equator, with these hydrophobic acrylic toric IOLs, I can still manage to put them in. Be very careful, and like Dr. Zhu mentioned, before the haptics open up, put them in their position, very gently guiding. So I have a couple of cases and the lenses remain very stable. If it's a posterior capsule rupture and if it's a small one, I would convert it into a posterior rhexis, do a vitrectomy, and then put the lens in the bag. But if it's large, then I think it's better to go for a traditional monofocal.
One other thing too is I've done, I think I've got 4 or 5 patients that I've done the Ambati technique with the LAL. So it can be used in that role as well, which is really slick.
Terrific. These challenging situations where you have a capsular tear, I think you really have to individualize the management of the patient. If you have a small anterior capsular tear, one thing I do is sometimes I'll do 2 or 3 other relaxing incisions so that the tear doesn't extend. And then if you have a posterior capsular tear, as Dr. Vasavada mentioned, you can do a posterior capsular rhexis, and or you can place the haptics in the bag and the optic above the anterior capsule. So there's a couple different approaches you can try. Last question, we're at the very end. Last question, and I'll pose this to Dr. Doan. This is from an ophthalmologist, I believe, in the Middle East. Why has the LAL not gained popularity and only a few doctors are using it even in the US?
That's not the case at all. In the US, there are literally hundreds of doctors using the light adjustable lens. I think that they need to get their feet grounded well in the US and start moving ex-US, which I think they'll do. So I think that I'm trying to remember the number. I want to say there's probably, gosh, I could be way under if I said there are 400 doctors that are certified to do it in the US. growing tremendously. Last count, I think they had about maybe 100,000 implants in the US. So it's growing dramatically.
Sure. Well, I thank you all. I'd like to thank Andrew Chen and Lauren Sicca from CyberSight for arranging this, and I'd like to thank all my fellow panelists, Drs. Doan, Vasavada, Hu, and Zhu. And have a wonderful day, everyone. Have a wonderful week.